Hi everyone, I'm going to be doing my flashcard presentation on type 1 diabetes. Working on a pediatric med-surg floor, we typically see a lot of new onset diabetic patients come in. They usually stay about 3 days, and it's all about patient education during that time, and these are patients that I really like to take care of, so I found this topic very interesting. Type 1 diabetes mellitus is an autoimmune disease characterized by the destruction of beta cells in the pancreas, which produce insulin. Insulin is the hormone that breaks down glucose in the body. Therefore, patients who are diagnosed with type 1 diabetes typically present with hyperglycemia. Individuals may be asymptomatic for an extended period of time before a diagnosis of type 1 occurs. Diagnosis may then occur as an incidental or asymptomatic finding. They may have the classic symptoms, which I will discuss in a little bit, or they may present in diabetic ketoacidosis or DK. DK is a severe complication defined as hyperglycemia with a blood glucose above 200, metabolic acidosis with a pH of less than 7.3 or bicarb less than 15, and ketones in the blood or urine. All forms of diabetes are diagnosed by either a fasting blood glucose level of greater than 126, a random blood glucose of greater than 200 in a patient who has symptoms of hyperglycemia, or an A1C of greater than 6.5%. A1C, or glycolated hemoglobin, is used more in type 2 diabetes mellitus as it shows a better picture of hyperglycemic status over a longer time frame for the patient. The difference between type 1 and type 2 is that type 1 involves insulin deficiency, while type 2 involves insulin resistance. Patients with type 2 are also typically obese, older in age, and have associated diagnoses of hypertension and dyslipidemia. In contrast, patients with type 1, otherwise known as juvenile or insulin-dependent diabetes, are usually diagnosed as children. They are typically thinner individuals, and the onset of their disease is acute rather than insidious. So some risk factors involve genetic components, so individuals with a family history of type 1 are at a higher risk of developing the disease, as well as non-Hispanic white youths. There is controversial discussion regarding the certain environmental components as risk factors for type 1, such as viral infections, immunization, certain dietary habits, obesity, and vitamin D deficiency. But the classic findings of new onset type 1 diabetes are polyuria, polydipsia, and weight loss. So polyuria, or increased urination, occurs due to elevated glucose levels that the kidneys cannot tolerate and therefore is excreted through urine. Because of the hyperglycemia and subsequent hypovolemia, polydipsia, or increased thirst, then follows. Weight loss occurs because insulin deficiency results in the breakdown of fat and muscle. Fatigue, dry mouth, itchy skin, and hunger can also occur. Patients in DK present with similar findings but in a more severe state, and it is typically accompanied by fruity smelling breath, lethargy, and drowsiness. So as previously stated, a blood glucose level and A1C would likely be drawn to determine if the patient is hyperglycemic. Additionally, urinalysis studies would be collected, and this would help to determine if the patient was in DK if ketones were present in the urine sample. This can also be done by urine dipstick. And then this is an image that I really like that explains type 1 in a much more simplified way. So if you imagine the cell has a door that lets glucose in, and insulin is the key that opens that door. But if there is no key or no insulin, or it isn't working, the glucose stays in the body because that door isn't open. Instead of being used for energy, therefore, it's excreted through urine, and this is what causes the primary symptoms of polyuria and polydipsia. All right, and here are my references. So thank you very much for listening.